Muy buenas noches para todos. Muchas gracias por la asistencia a Noches de Trasplantes. En esta oportunidad vamos a tener el honor de escuchar al doctor Ethan Moore. Y el doctor Ethan Moore es profesor de cirugía de la Universidad de Tel Aviv, jefe de la unidad de trasplante y del departamento de cirugía del Centro Médico Shabá en Israel. El tema que vamos a tratar hoy es desensibilización para el trasplante de riñón con incompatibilidad ABO. Thank you, Dr. Moore, for your meeting, and it's a pleasure for us have you in this presentation. Thank you very much.
Thank you for giving me the opportunity to present this topic, which is very interesting to me. Actually, right now hosting one of your fellows, Ivan Martin, who is very active in our program, and I'm glad to host him. He made us, to talk to each other, and I'll start my talk. And the talk today is on desensitization in two scenarios. One is ABO incompatibility, and the other one is HLA, the incompatibility. So ABO antigens, as you know, are composite sugar chains and exist on all cells, red cells, endothelial cell, epithelial cells in various organs, and they are preformed antibodies. And the source of these antibodies during childhood is actually a cross-reactivity with GI bacteria. So many of us actually are born with, or during the first year, born with this preformed antibody. And the reason these antibodies are important in transplantation is because when you do ABO incompatible transplant without any desensitization, you'll get what we call in the past hyperacute rejection or antibody-mediated rejection via activation of the complement system and endothelial damage and activation of all the inflammatory process cascade, which cause finally thrombosis of the small vessels and loss of the graft. Today, with the immunosuppression, if you don't do any desensitization, you'll get a loss of graft within days or maximum 2 to 3 weeks. And the characteristical histological picture is, as I mentioned, infiltration with inflammatory cells and thrombosis in the vessels. But one feature which was recognized almost 15 years ago is if you stain for C4D, which is a component of the complement system, you see it on the peritubular arterioles all over the graft. Very interesting that in contrast to the HLA incompatibility situation, you'll find it even if you don't have any tissue injury, meaning that there is some phase in which you get the neutralization of this reaction in a phenomena called accommodation, which I'll touch in a minute. But this is a publication from 2004 showing that if you do a protocol biopsy on these patients, you see it even months after, you'll see the C4 staining with a normal graft function. And you can see it also in the other situation of DSA in a positive cross-match. So accommodation is really a unique phenomena for ABO incompatibility. It's actually a resistance of the graft to antibody-mediated rejection despite the presence of these antibodies and the presence of C4D deposition. And there are some proposed mechanisms as written in here, but it's actually neutralization either of the antibody function or some change in the cell on a cellular level in the endothelial cell. So the clinical history of ABO mismatch transplant is back to the early 80s where Dr. Slapak from New York actually described a way to overcome this phenomena by doing plasmapheresis. And he succeeded in the first case of incompatible ABO transplant. Later, he described in the 90s a series of patients showing fairly nice results with a survival rate of 87% by using only plasmapheresis and the regular immunosuppression at that time with cyclosporine. There is another phenomena that if you have a combination of A2 kidneys to O or B recipients, the A2 doesn't present the regular A1 epitope, and it's probably the reaction is much weaker, and you won't get any antibody-mediated rejection in this scenario. Another step forward was neutralization of the B cell mass by doing splenectomy, offered by Guy Alexander from Belgium. But overall, at that time in the 80s, probably related also to the immunosuppression, is that the results were not considered satisfactory, and the procedure was actually abandoned in most countries in Europe and in the United States. However, in Japan, since they don't have available disease donors, they continue to do this, and they changed their protocol from doing splenectomy to do rituximab. As you can see in here, they use the protocol of double filtration plasmapheresis. Hold on a second. With splenectomy in the early phase of their experiments, and then they change it to rituximab given immediately prior to transplant. They also started immunosuppression 6 days before the transplant, which is probably a very important way to neutralize also the T cell arm. And their results were published, as you see, in 2004. And as you can see, the late era, the results of the patient survival and graft survival were superb for, as you can see, 9 years of follow-up, which is quite similar to the regular transplant that were done at that time. Just reminding you that all these transplants are live donor transplants. So going back to the Western world, actually, Laurie West from Sick Children Hospital in Toronto described a series of 23 children who received heart transplant with only 4 deaths, incompatible graft with only 4 deaths, with no significant difference in survival at 4 years for transplant for the ABO and the ABO mismatch group. But just reminding you that these infants have undeveloped anti-ABO antibodies. So it was quite expected that this group of patients will be favorable with the ABO incompatible transplant. Now, actually, maybe the seminal paper from Bob Montgomery was published also in the 2004, describing his protocol of initiation of immunosuppression and several sessions of plasmapheresis. And he also used the same protocol as the Japanese, rituximab given a day before the transplant. And quite surprising for me, they use daclizumab induction and not thymoglobulin induction. But they followed also with plasmapheresis after transplant, and their results were as good as the published SRTR data at that time. So desensitization measures are based on, first of all, antibody removal by plasmapheresis or immune absorption that I'll mention later on. Immune modulation by giving IVIG. There are some who give only the low dose of 100 milligram per kilogram or high dose, which is up to 2 grams per kilogram body weight. And B-cell depletion by introduction of rituximab. There are now new preparations that neutralize plasma cells like bortezomib and complement inhibition, which is used mainly to treat very early rejection. So the plasma exchange is the historical, which is still used today, removing the IgG antibodies. In each session, you remove about 20% of the antibody. The double filtration plasmapheresis is more efficient, more effective, and actually, it also allows smaller molecules to return back to the patient, avoiding many complications associated with plasma exchange, which actually remove also the coagulation proteins, procoagulation proteins. The immune absorption is more specific, and there are now columns that are specific to absorb the anti-A or anti-B, or just overall human IgG antibodies. You all have heard about the IDES, the staphylococcal protein A that remove all the IgG. But in the practical world, most physicians or most programs will use the regular protocol using plasmapheresis with IVIG and rituximab. So this is the logic behind using IVIG, replace the patient immune globulin, block the Fc receptor, inhibition of the complement activation, and inhibition of circulating antibodies against HLA. And of course, B-cell depletion is actually removing the B cells that later on develop into plasma cells that produce the antibodies. So you prevent ongoing rejection by giving this. I would say, breakthrough is the use of specific anti-A or anti-B columns that are hooked to the plasmapheresis machine. And what you do is move specifically only these antibodies and return all the plasma proteins back into the system. So you can do it even at the day of the transplant. And it's 4 times or 3.5 times more effective than one session of plasmapheresis. Meaning that you can, if you start with a very strong reaction or with dilution of 1 to 64, probably one session will take care of it, of this column, glycosorb column, which is produced, by the way, in Sweden. And this is the first series that was described in 2008, combined efforts of the group from Germany and from Sweden. And this is the protocol. And as you can see, the glycosorb, in this case, remove in one session 3 dilutions from 64 or 32 to 1 to 4. And another set actually came down to levels that were actually allow transplant with no antibodies at all in the periphery. In their series, they describe 60 patients with a survival rate of 97%, with perfect creatinine on the follow-up. And the follow-up is rather short, but just reminding you that once you overcome the first 2-3 weeks, actually the transplant is the same, the results are the same as a regular transplant if you don't have acute antibody-mediated rejection during this time period. A group from London, Guy's Hospital, actually described more, I would say, different protocol tailored according to the strength of the antibodies. And as you can see, if you have a low antibody level, they haven't used any rituximab. If it's 8, they use rituximab. If it's more than 1 to 64, then they are using also the COM, immunoabsorption. In their protocol, in their series that was published in 2012, they actually allow to go straight to transplant with a titer of 1 to 4 or lower, and there is no need for desensitization with a titer of less than 8. They had 13 who received no pre and post-transplant antibody removal. None of these patients experienced ABMR. So the use of this tailored approach, a stage approach of, according to them, was very useful and saved also some unnecessary infusion of rituximab and plasmapheresis. This is another series from Australia, Melbourne. This is quite similar to the protocol that we have used, starting with immunosuppression and plasma exchange and low-dose IVIG, and they also use Simulec induction. In their series of 37 ABO incompatible recipients, they had a success rate of 100% at a median follow-up of 26 months. They did have 8 rejection episodes, 2 AMR. Only 2 of those were AMR. This is my experience from my previous job at Bellinson. We have done desensitization in 36 patients. All had a PRA of 0. And this is our protocol. As you can see, we use rituximab and plasmapheresis, IVIG, and low-dose immunosuppression starting 2 weeks before transplant. And we aim to the same protocol as the Guy's Hospital below 1 to 8. This is the relationship. And this is the combination, mostly to O recipients, which is the most common situation, because otherwise you have ability to execute transplant. And this is the experience of 36 patients. You can see 3 or 4 episodes of AMR. With 2 graft lost, 1 at day 9, 1 at day 15. 1 AMR was taken care of and resolved. And as you can note, that those who develop AMR started with dilutions with a very high level of 1 to 28. This is 1 to 28. But we did have another episode of AMR, as you can see in here. Starting at a level, the blue line is the baseline titer of 1 to 4. And this patient was not given rituximab. So since this case, I'm always using rituximab. And another very important point, which I'll go back to it in a minute, is the monitoring of antibody level after transplant. But overall, the results were quite good. This is creatinine values dropping over time in a Hebrew way, right to left. And this is the overall graft survival over 5 years. We lost 1 graft for venous thrombosis. It might be AMR, acute, hyperacute type of AMR. And 3 experienced AMR, 2 grafts were lost. And 1 patient died 22 days after transplant with functioning graft. So the current desensitization protocol allows for ABO incompatible transplant with good long-term results and should be used mainly in O patients, O recipients. The risk of AMR is increased in patients with baseline antibody levels above 1 to 128. An important part of the protocol is a tight post-transplant antibody monitoring, daily monitoring for the first 2 weeks. That's why we keep the patient for 2 weeks after transplant. And once you see even one titer, one dilution elevation, we start plasmapheresis and we give the full treatment. Immune absorption is advantageous of allowing more effective reduction of antibody titer rather than to repeat the session of plasma, and it doesn't remove all the coagulation factors. And the role of rituximab, I believe that in this situation, you rather use rituximab in all cases. This is actually the summary: incompatible live donor, ABO incompatible. If the recipient is non-O, we usually nowadays use the pair exchange program. If the recipient is an O blood type and the titers are below 1 to 28, we can do desensitization and go ahead to transplant. Our cutoff here at Chiba is 1 to 64, just one dilution below. That's because we don't have the available column. If we did have the column, I would use the column and do even 1 to 128. If the titer are high, above 128, I would recommend to go to pair exchange program. So the same actually apply to the desensitization in the presence of DSA. DSA is produced with sensitization, as you all know, by previous transplant, blood transfusion, pregnancies, and in the mid-2000, the desensitization protocol was introduced as a potent solution for high-risk transplant across a positive cross-match. But the introduction of pair exchange program has set aside this option that should be, in my mind, reconsidered in certain scenarios. So this is again the same person, Robert Montgomery, that published his series over 10 years period. He used a similar protocol with low dose IVIG, and the number of sessions actually dependent on the baseline DSA level. He wanted to see a reduction of the antibody level before going on with transplant. And the immunosuppressive protocol included the clizumab, thymoglobulin, Prograf, CellCept, and steroid. So he had used the combination of the clizumab and thymoglobulin. And this is one of the figures, a very important figure from his publication at that time. The desensitization treatment is much better than to keep these patients on dialysis or keep this patient until they will have the opportunity to get a matched transplant, as you see in here. The same scenario can be done also in the case of disease donation, and this is a series published by Jordan, and they use IVIG and rituximab, and he described 13 cases with quite nice results in this initial experience. But what struck me is that, if there are some others who publish their experience without using any desensitization protocol, showing at least in the low level of MFI, quite nice results without doing any desensitization. So this is the clinical significance of DSA positive, low cross-match negative. This is the name of the paper. And their 1-year acute rejection rate were similar in DSA positive versus DSA negative patients, 15.4 versus 11.4, and were higher as expected in patients with mean level of MFI above 3,000. And they had quite nice results, as you can see in here. 5-year death sense of graft survival of around 90%. So their conclusion that pre-transplant DSA in the setting of a negative cross-match confers minimal immunological risk in the intermediate terms and does not necessarily necessitate desensitization therapy and should not represent a barrier to renal transplantation. Saying that, I would rather continue using desensitization in levels of MFI above 3,000. Maybe you have to tailor your protocol according to the level of the antibodies. So if you have a very low level, that's what we are doing here today. I use only rituximab. If they are level above 6,000, I use one set of plasmapheresis and then check the antibody level. If it drop is below 2,000, then we can go on to transplant. So I think when applying this protocol, you have to think about each of the patient and tailor the desensitization protocol according to the sensitization degree of sensitization of each patient. So this is our experience from back when we have done it at Bellinson. 37 patients this year was was published in Transplantation just 2 years ago. So we used two different protocols. We started with protocol without rituximab for low levels, and for the high levels, I used rituximab in 17 patients, and this was the same protocols as I've shown you in the ABO incompatible setting. And we compared the two groups of 20 patients receiving rituximab, those who didn't receive rituximab. You see that this is the patients. Many of them underwent second transplant, third transplant, fifth transplant. But there are some who had their first transplant, mainly women who had previous labors. And the mean MFI at baseline before transplant was 8,400, ranging from 3,500 to 16,000. On the follow-up, we have 3 patients who develop AMR in the no rituximab and only 1 patient in the rituximab group. We experienced 9 graft loss, 6, and this is almost 8-year follow-up. Chronic rejection, which is, I think, is a very important outcome in this scenario, because what we used to do to look at is to the immediate outcome of the rate of antibody-mediated rejection. But this patient, as we know, may rebound their DSA and develop chronic rejection. So here we have 6 patients developing chronic rejection, 1 recurrent disease, and 2 patients died with functioning graft. And the overall 1, 5, and 10-year survival were acceptable, I think. Again, in the Hebrews time, from right to left, you can see the monitoring of the DSA levels prior at baseline, prior to transplant, post-transplant 2 weeks, and then on the follow-up. And this is only part of the patients. As you can see, the DSA, this is the last DSA in blue, that very few develop DSA on the follow-up, and usually it's not a preformed antibody, it is de novo antibodies, new antibody that develop after transplant. So against the donor, the current donor. And here is the graft survival with and without rituximab. It was not significant because the groups were small, but there is a trend. When I moved to Shiva, we use the same protocol. This is just one. Oh, sorry. The errors are So this is a 33 years old patient who is undergoing a third transplant with a PRA of 30% in class 1, 28% class 2, and 6 HLA mismatch with the donor. And as you can see, we started pre-transplant with this level. After desensitization, and this is post-transplant, which is actually just a background. And he's still going very well with his first transplant. So I think there is a room to do desensitization even today in the era of pair exchange. So for summary, short-term results after desensitization protocol in the highly sensitized patient undergoing kidney transplantation are good, but the long-term outcome is hampered by early development of chronic rejection. The addition of rituximab to desensitization protocol seems to protect against antibody-mediated rejection and thus should be given in the low DSA recipients. It's the same philosophy as I use also in ABO incompatibility. Despite the advantage of pair exchange program, the option of desensitization should be considered in a very high level PRA who is hard to match, for whom a low-level DSA donor is offered. So you have to allocate the right donor with low-level DSA, do the desensitization, and proceed with transplant. And this is actually adopted from the Bob Montgomery, a great man. I guess you know him also. So if you have an incompatible live donor with a positive cross-match, if he is difficult to match and have an AB donor and broad spectrum of sensitization, but you find the appropriate donor who is, and you can do easy desensitization with low DSA strength, and you achieve a negative cross-match by flow. I would recommend to do desensitization in these cases. Of course, if there is a very difficult scenario, difficult to desensitize, high titer DSA, then you do KPD, followed by desensitization. And in the situation of easy to match, an O donor, but difficult to desensitization because O donor is favorable in pair exchange program, then the chance of this patient to receive in a pair exchange program kidney, you should put him in a pair exchange program. So we spared the desensitization protocol for quite a low portion of our patients, not all the patients. But if they wait and they are not able to get kidney in the pair exchange program, our pool is not that wide, then we do desensitization. I would stop in here and wait for your questions. That's a paper that published in the 2015. You can see you can use also bortezomib or rituximab in desensitization protocol. This is a paper from the Mayo Clinic showing that bortezomib is also an option for desensitization, but I don't have much experience in that. Thank you.
Thank you, Dr. Moore. Very interesting, the meeting. We have a problem with the hours from Israel and Colombia. So we are going to send you by email the question. In this moment, I have 3 questions to do. What about with the infections, with the infective complication of these patients in your group?
In the paper that was published, I can look for the reference. We looked at the infection complication, and the infection complication were not higher compared to non-sensitized patients. So I'm not afraid, but of this, I think these patients, this group of patients are considered high-risk patients, and this is their only chance. And if they have UTI, I wouldn't count UTI as something meaningful in the long term of that graft.
Okay. Okay. The next question: what are the relevant antibodies to monitor it before and after the transplant? IgM, IgG,
IgG.
are more important than AG?
Yeah, IgG is more important, and also in the ABO incompatible transplant, you can do it in flow cytometry, which is more accurate measure to do it. But we use dilution. You know, you do a hemagglutination test. Once it become negative, then that's the dilution that is marked as the level of antibodies. Very simple and quite qualitative to the flow cytometry method.
Okay.
So IgG, yeah.
Thank you. And do you have a special consideration if the patient needs a blood transfusion or a plasma and blood?
Yeah, of course. If you give a B, let's say B donor to O, then you have to use B plasma.
Okay. Okay. Dr. Moore, thank you very much. It's a pleasure for us to have you here in that meeting. That meeting is a month meeting in Colombia for all nephrologists, hepatologists, and surgeons that had worked in transplant. Thank you very much.
Thank you, George. Thank you for the opportunity to present our experience. And I hope you'll start also ABO incompatible if needed.
Yeah, it's true. Muchas gracias a todos. Las preguntas las podemos enviar, si tenemos más preguntas, las podemos enviar al correo del Dr. Moore. Él muy amablemente nos va a ayudar a responderlas. Muchas gracias. Buenas noches.
Buenas noches.